function, and that's the method by which we plan to do most of our dialogue today. We would really encourage participants to tweet along with us, and obviously participate in any way that they feel appropriate that way. My colleague will be including the website and links within the chat so that people can look a bit more in a bit more detail about the network itself. And just to advise participants that we are planning to record this session and make it available to those people who've been unable to attend. Thanks, Anne. So we just move on. So just by way of formal introduction then, my name's Louise Dauncey. I'm a Network Delivery Manager for the Child Health and Wellbeing Network. My main role with the network is to oversee the delivery of the Children and Young Persons Transformation Programme. In terms of my professional background, the last 16 years I've spent doing health and social care commissioning for adults with learning disability and complex needs, and more recently children and young people with special educational needs. Came to the network in 2021 in September. We have our chair, who's Dr. Ria Willoughby, who will introduce herself more formally later on. But just so that you know who's taking you through the day today. If you could just move on. Thank you, great. So as I mentioned at the beginning, we're lucky today to have a huge turnout, not just necessarily from the geography and across our footprint, we've also got really wide representation from the system. We have representatives from the acute and mental health trusts and various NHS organisations, including clinical commissioning groups and commissioning support units. We've got local authorities, so commissioning and delivery leads from local authorities, stakeholders, parents, parent carer forums and various voice groups, as well as a multitude of private, voluntary and community sector organisations, as well as education and further education providers. So a huge thank you to everybody, and hopefully it will be a really productive session with all of those participants from across the system. If we just move on. Thank you. So really, just to give a very basic overview of the Child Health and Wellbeing and just a summary of its strategic fit, really. The Child Health and Wellbeing Network is a Northern Clinical Network. It exists primarily to connect different parts of the system to be able to drive quality improvement. For the network itself, there are growing responsibilities in relation to the delivery of the Children and Young Persons Transformation Agenda, which I'll go into a bit more detail as we move forward. Next slide, please. Just to give a bit of a background to the network and to describe its evolution over the last 3 years. A number of engagement activities took place involving thousands of professionals and stakeholders who were engaged in various different types of engagements. The membership has continued to grow in number and also reach, and these engagement activities have been able to identify a series of priorities for the network. Next slide, please. So the vision of the network is essentially about organisations working closely together to allow children and young people to achieve their best, and basically to flourish by our productivity and systems thinking. The ask of the network was primarily to connect organisations to enable that collaboration. So it's just really this is our mission statement. This is what we're all about as the network. Next slide, please. So this visual here represents the priorities that have been identified through the engagement activities. We originally had 9 priorities that had been identified, but we've revalidated that with stakeholders in January 2020, following the first wave of the COVID pandemic, and it was felt by the system that there was an additional priority that was identified as a gap, which was around family support. So we now have a priority reel with 10 priorities included. Next slide, please. Thank you. And this, I appreciate, is a really detailed slide and quite complicated, so I won't spend too much time on it. This provides an overview of the historic programmes of work. Some pieces of work do remain ongoing. This really is just to demonstrate the breadth and diversity of the work and the types of projects that we're involved in with the network. It also attempts to demonstrate how agencies are being enabled to work together to be able to deliver on these projects. And you will note from the colour scheme that these projects that we have as part of the network support us to deliver on our priority areas that had been determined by the system that I just referred to on the previous slide. Can I ask you to move on, please? So, as I mentioned, Children and Young Persons Transformation Programme, the network itself has a bigger and growing responsibility around delivery of this. Essentially, the Children and Young Persons Transformation Programme is a credible plan about the delivery of the long-term plan and its commitments locally on the NENC footprint. Next slide, please. The Children and Young Persons Transformation Programme has three main aims, which is about integrating services, improving the quality of care for children and young people and their families, and also for the involvement and engagement of young people in policy and decision making. I won't go into detail just purely down to time, but essentially there are 10 priorities. You'll see by the slide here that transitions is one of those priorities, which is looking at developing a joint model or a joint approach to care for children aged 0 to 25. So we've undertaken local work as part of our programme of work to scope and baseline services, which Dr. Thwaites and Dr. McCurling will give more detail about later on in the session. Next slide, please. Again, this is a very busy slide, so I won't go into too much detail, but this just gives a bit of an overview of our accountability and governance arrangements within the network. Essentially, what this is showing is that we have a series of projects that report into various boards, which ultimately is accountable to the Optimising Health Services Board via the execs. The other thing I wanted to particularly highlight is in relation to the Children and Young Persons Transformation Programme reports into the NEY Regional Oversight Group. So I, along with peers from other NEY ICS areas, are reporting directly into that group. It's also important to highlight the young advisors, that we have an executive board of young advisors who run in parallel to the main executive board, and the purpose of that is to allow them to influence the direction of the network. So this just brings me to a close now. It's really important for us to recognise our responsibility, our moral and professional obligations and duties to advocate for young people. We talk all the time about systems improvement and key delivery tools and programme delivery, when what we really need to be clear about is why we're doing this and remember the end user. So this is just to recognise really, and I suppose reflect why we're here today and what's important, so that we can support people to live happy and healthy lives. So that brings me on. Next slide, please, Anne. Just to close, really, just to say that we are really excited about today, and we look forward to hearing from you, and would encourage you to contribute in the chat function, and obviously to continue to engage with this work as it goes forward. And I'm going to hand you over to Ria, who is our chair for today. Thank you.
Thanks, Louise. So I'd like to just welcome everybody. As Louise has reflected, there's a number of different people across organisations across the country that are joining us here today. So please do use that chat. I know some people have put hellos in already. If you could just let us know who you are, where you're from, it allows them that connectivity that's so important in terms of sharing good practice and connecting people, because that's the key bit of the network. We're going to change the agenda just very slightly, just to try and make sure that we have enough time to have some of that conversation, because that's the core element of our huddles for the network. So we're going to introduce you shortly to our first speaker. We'll follow that with our second speaker, and then we'll have the conversation time and the questions at the end, so that you can speak with both of them together. So without further ado, it is a tight agenda. I'd like to introduce you to Dr. Gail W. Pearce. We're fortunate enough that she's one of our colleagues up here in the Northeast, in Northumbria, and in terms of working with us, not just clinically, but here today talking about the adolescent brain and some of the work that she's done for the NIHR project that she's been leading. So over to you, Gail.
Thank you very much, Louise and Ria, and that's a lovely introduction to hear the important work of the network. So thank you for that. So I've got a slide deck that could cover all morning, and I'm kind of, the apology is I know that there will then be the dissonance of hopefully wanting to listen to me, but also the urge to read through some very detailed slides. I made the decision to keep the slides detailed because I'll talk for 20 minutes today, but there's much more in the slides then that I'm obviously, I presume you're sharing them to all participants. There's more resources, background, reading and detail in the slides that you can go to after today's talk, but I'm afraid I will be whizzing through some of the slides. I'm going to be talking about adolescent neurodevelopment and, importantly, what that means for our work as practitioners, parents, people alongside young people. So we'll cover some of the key concepts, neurodevelopment, and then importantly finishing off with why it matters to our work. Excuse me, I understand that I'm obviously, you know, preaching to the converted on this call, but I hope there's some new knowledge in here that will help us kind of further inspire us in our work. Thank you, Anne. If you move the slides on, great. Oh, there we go. And again, please. So the first couple of slides are about the numbers, just the key concepts. This is stuff you'll already know. And the next one, please, Anne. We could get bogged down in the numbers and how we organise our services and our service criteria and things like that. But obviously, it's not about the number. Next again, please, Anne. In broad terms, in terms of psychological processes, we think about identity development in adolescence. So beginning to get that sense of who we are from childhood onwards, really beginning to build that sense of what our preferences are, how we want to be, how we want to behave, who we want to hang around with, all of those kind of things through adolescence. And as those begin to form, we then explore them into young adulthood. And, you know, I think it's a lifelong process, but no time more so than in that move through adolescence and young adulthood, as we move from understanding the aspects of our self-identity and moving into a more coalesced sense of self-concept that's stable and hopefully, you know, under all good circumstances for development, leads us to have a pretty stable sense of self that will endure and support us through adulthood. And those are some of the key tasks that we think are important. Few exemplar quotes here. In childhood, you know, your friendships are a matter of chance, and then through adolescence, it becomes more choice. So at first, it really depends where your parents have decided to live and which school they've decided to put you in. And if we're lucky, you know, some of those friendships endure through adolescence and into adulthood. And that's always lovely to hear in my work and seeing my own children grow, that some of those endure. But equally, we want them to branch out a bit then as well, don't we, when they get a bit older and start making some of their own choices. Again, please, Anne. Another quote here that, you know, that I think I see it quite a lot, that need to belong to a group, have that confirmation of those emerging sense of self-identity aspects, but also understand what's unique and special about, you know, ourselves. And that is a bit of a struggle, but certainly sometimes not wanting to be like our parents at all. Sometimes, no, not often. And the next one, please. So this really, this is a paper, a professional, an academic, actually, an American academic, whose work I really rate. And this, again, just says what I've already spoken to, that self-identity through childhood and into adolescence are those personal attributes that we sort of pick up, try for size, develop, you know, we kind of see ourselves in relation to our peers. Well, how much on this spectrum of this value am I over here with this lot, over here with that lot, or am I somewhere in the middle? And you're doing all of that relative exploration, relative sort of development and positioning. And then into later adolescence and young adulthood, a sense that those really begin to gel with experience. So not by sitting in your room and thinking about it, but by getting out there, trying things for size, making some mistakes, you begin to understand what your response is to some of those things that you've been developing, and you maybe you do shape them, you maybe get rid of some that you thought you were but don't want to be, you develop new ones, you continue to meet people through life, but into young adulthood, the idea is that they sort of gel together and become relatively stable. Again, as long as all the factors are there that are helpful for young people to go through what is a really complex internal psychological developmental process. Thanks, Anne. Busy slide. I'm sure many of you on this call will be familiar with the Lancet Commission paper from a few years ago now, but still really, really important. Just saying why it's important that we understand these kind of things about young people in terms of their health, the impact upon their current, the triple dividend. If we support young people, that's going to help them with their current health and well-being requirements. It will stand them in good stead for their adult development. Again, given what Ria and Louise have just explained, I know that I don't need to explain this to those of you on the call today, but then actually all of that influences the outcomes for their children and the generations beyond. So if we're talking about preventative health care, I think we're really privileged to be positioned where we are in working with young people. Those with physical health needs, developmental needs, learning needs, the health inequalities we need to really grasp. So again, fantastic to hear that front and centre in the work of the network, and thinking about preventative approaches and working with some of these systems barriers, including some of our own doing, in terms of separating child and adult care. For example, it would be really interesting, especially thinking about the neurodevelopmental evidence, that actually it says 20s in my talk. The papers now say at least on into our 30s and probably a bit longer than that. How many of us are child health professionals on the call today, and how many of us are adult health professionals? Because actually, beyond 16, 18, 19, we need to be engaging with our adult colleagues as well. So a perennial challenge. For those that know me, I'm always banner waving about that particular one. Next slide, please, Anne. So all of that, as well as making really big choices, having a different sleep pattern to the rest of society, having to now navigate social media, which makes me all feel very old and actually quite lucky that I didn't have to, but needing to understand it now as a parent and as a healthcare professional, and undergoing a massive reorganisation of the brain. So into the next section, where I'm going to talk very briefly about some of that neurodevelopmental evidence, really exciting, and where Britain leads the way in terms of the research. Please, Anne, thank you. And on again. Fantastic. So the technology has really moved on in recent years, enabling a much better understanding. That's all I'll say on that one. If we can move on, please, Anne. These are the busy slides. Try to resist the temptation to read this one. You can go back to it, and that's why I wanted to keep it in. But essentially, the executive functions in our brain develop later than some of the more motor functions and more base functions. Our cortical grey matter and our subcortical grey matter, and what they're responsible for, things like impulse control, executive control, planning, emotional regulation, they develop later. So essentially, in an inverted U shape, we get from childhood into adolescence, we develop nice, thick, juicy grey matter, lots of potential, lots of different connections, motorways, A roads, B roads, country lanes, loads of connections in there. From adolescent onwards into young adulthood, into adulthood, we begin to lose grey matter, but that's okay, because what happens is, use it or lose it, all the connections that we're using most through childhood and into adolescence begin to get pruned back and made more efficient. So it's okay that we go from a real sort of primed brain to then a more efficient brain, and the pattern of development kind of does that over the top, and then there's a little tuck back there in terms of the areas that are getting developed in this way first and then later. So a little bit of an imbalance between the brain areas, but again, that's okay, and I hope to reassure you about that in the next 10 minutes while I finish the talk this morning. If we can move on, please, Anne. The white matter is the sort of insulating, the linking pathways between those grey brain areas, and that develops, that thickens, and our connections get more insulated in a very linear increase through adolescence and into adulthood, meaning that the areas can share information and share processing between themselves most efficiently, and make sure none of that gets lost as all our pathways get nicely thick and insulated. Next one, please. And finally, this morning, the neurotransmitters, the chemicals whooshing around all of those connections between those brain areas, the dopaminergic pathways responsible for reward seeking and also reinforcing learning become primed during this time, and oxytocin receptors proliferate during this time, and that's thought to be implicated in social behaviours, bonding, and reaching out beyond the core group. So lots and lots of neurodevelopmental changes, and I put some a final slide in with the papers that I've gone to, you know, I'm not a neuropsychologist, I'm a psychologist with a fascination of this area. So I went off and did the reading, and it's, you know, the likes of Sarah Jane Blakemore, Jay Geed, some of the references that I've put in do make this reading really, really accessible, I think. So please do go to them. And the next slide, please, Anne. So, what does all of that mean? And I appreciate that was a bit of a rush through, but particularly this idea that our sort of executive, what we sometimes refer to as our internal policeman, you know, making sure we don't say the things we maybe are feeling inside, that we're inhibiting responses, that we're making reasoned choices based on memory, based on experience, as that experience is developing, you know, and things like our impulse area of the brain is drawing upon past memories of, oh, that didn't go so well. Do you know what? That's my impulse, especially if my peers are about to go off and do that. But you know what? I'm not going to do that. You know, those kind of balancing up the work of the different parts of the brain. The idea that have proliferated, you know, up until recent, you know, well, that's always been around with all of this is, you know, because the adolescent brain is imbalanced, it's therefore a little bit irrational, it's a little bit not ready for purpose, you know, but the idea that our brain isn't fit for purpose until we're now into our 30s and things doesn't quite stack up to me and some, you know, some other writers. So maybe actually this slightly kind of developing at different times brain, it is a bit adaptive. You know, maybe we are primed to be a bit novelty seeking, risk taking, taking some experiments, you know, making some experiments, taking some social steps out of the family of origin, which is a hugely, you know, in terms of, you know, we've all seen the David Attenborough elephant wandering off into the desert. You know, we send our child off into the desert to do the, you know, it's an incredibly risky thing to take those social steps. Maybe the brain needs to be primed to help us do those things. It's a theory, but actually my big point and highlighted is, let's not take too many leaps of logic. You know, the size of the brain area, that the amount it flashes up in terms of oxygenation on those new sort of images that we see on, you know, horizon and things like that, and the amount of neurochemical that we can test slushing around in those pathways, is that the whole picture? I don't think so, and I'm going to spend the next couple of minutes trying to persuade you why I'm thinking that. Next, please, Anne. Jay Geed, an American academic, really a good writer. So saying, yes, the brain drives everything we do, but the brain is in context of lots of different factors. So yeah, I'm going to speak to that a little bit more now, if we can move on. Just aware of the time. So, risk-taking. Okay, the brain is primed for sensation seeking, and the behaviour bears that out. Is that to do with this temporary imbalance theory? Is it to do with the changes in the dopaminergic activity in the brain? Well, maybe. However, the rise in the striatal pathways are really priming the learning that can come from different experiences, suggesting actually that sort of adaptive, rational way that the brain is beginning to make sense. And actually, if you go back to Kathy Sharmaz's work, her paper that I referenced there was from the 90s, before any of this data became available, neurodevelopmental data became available. Her point of young people having to go out there and try things out, try things for size as the way to develop their more stable self-concept. One could think that maybe the brain is priming us to do that. The other thing is, we all know adolescents do understand the risks. You know, in clinic, yeah, I'm not taking my insulin as regularly as I should. I know what those risks are. You don't need to tell me. You don't need to bang on about it again. And we all have to try and inhibit our own responses to bang on about it again and work out actually the discussion that does need to happen. They do display impulse control a lot of the time. They do regulate their behaviour. If you listen to what is behind some of the behaviour, they can tell you why they did it and why they didn't do some things. Yes, they make some exciting choices in certain situations, but do you know what? We all do too, don't we? You know, we all kind of understand when we've kind of done something that we didn't plan to, but we did anyway, and actually it was a bit of a choice. So it's not just adolescents that are at this kind of stuff, yeah? So again, for me, this is about, yes, the brain, yes, adolescence, but actually, let's not be stereotypical. Let's not take the evidence too simplistically, too much in isolation, and actually begin to build really sensible concepts around this. Next slide, please, Anne. This is a really good paper that I read. It's one that I found for this talk today, that I'd urge you to read this one. I think I've referenced it at the end. Moving beyond the stereotypes and placing what we know about the brain in that developmental, social, psychological context. For example, the importance of distinguishing between sensation seeking and the difference there between impulsivity without choice and how that can be problematic, and the impulsivity with choice, like I say, that we probably all do. You know, I was on a website and I decided to order that jacket even though I didn't need another jacket, but you know what, I'm going to do it anyway. You know, didn't plan to, but I did, and that's okay. That's the choice I made, kind of thing. Daft example, but we need to be sensible with the concepts. So I am aware that I do really need to rush on now. So Anne, if we can probably skip through that one. I've again, that one was about, I've weighed up the evidence for the social aspect around young people. Essentially, the top and bottom of it is the brain primes us, but actually the social context actually influences brain development. So this is another really important slide I wanted to cover today. This is the newest research, got started just before pandemic, but actually fantastic that's in place through and beyond the pandemic. An American cohort study, massive big data technology, making that technology and the data, well, making the data available widely so people can go in, pick out the data and write papers on it to show how social, developmental, relational experiences interact with brain development to lead to outcomes for young people. This is a game changer, this study, and maybe as a network we need to think about how we could, you know, learn from this and maybe understand if we can think, you know, access data or think about a UK approach to something like this. So again, I'd urge you to look at this. The papers are going to be coming thick and fast. The next slide, please, Anne, is one of the very recent ones I've picked out. It's Modabinia, I think is et al. is the pronunciation, 2021 paper, already showing that actually the social context, the experiential context, actually impacts upon the development of the brain. So it definitely is an interaction. So I hope I've managed to persuade you there that we just need to make sure we're thinking about all aspects of the data, the evidence and the concepts. So in the last 1 minute, I think, if we can move on, please, Anne. And again, please, Anne, what does this mean for our practice? We're part of the context that's going to be influencing a young person's behaviour, but maybe also their brain development. Our clinic, our department, our ward, our working relationship with the young people we're working with, our parenting of our children is all the context, you know, all adding to the context around them. We're part of that context. So a very quick whiz through. I think most of you will be familiar with all of this anyway. So Anne, if we could have a quick fire through the last few slides, please. Lovely paper. Young people, professionals, parents, when we're all in the consulting room, we're actually all worried about the same 4 things. Oh my God, what are we going to talk about? What's going to be done with that information that we talk about? Can I have my parent with me? Can I not have my parent with me? Should I be involving the parent? Should I not be involved? When to involve the parent, when not? And actually just having that warm, engaged human contact through this period. And the next, please, Anne. Examples of good practice there. Have a quick skim through there. There's nothing there that will be a surprise to anyone. My other soapbox, explaining privacy and confidentiality and acting upon it, but lots of lovely ideas. And actually, I don't need to speak to this because there's some speakers today that will give this much more time than me this morning. And the next couple, please, Anne, that bring me to a close. I'm sure this will come up again this morning. The expanded heads. And in fact, it's not heads, it's HEEAAD, you know, yeah, but now threads, building in transition and medication, to think about all the things we need to hold gently in mind. This isn't a checklist. This isn't a consultation tool in its own right. It was written as something for us to hold in mind and lean into all the different bits as we need to through the duration of our contact with different young, you know, with people at different times. And the next one, please. I think I'm nearly there. I'd urge you to think about connectedness, that your connection with young people, particularly if you're going to have connections with them for a longer time, but actually even if it's a one-off contact in A&E, really important. Young people are weighing us up all the time. They are moving beyond diagnosis or a health trauma through to be adult users of healthcare. Our experience, the experience we give them at this stage is really, really important. And if we get it wrong, we could set a bit of a rabbit off for a long period of time. So no pressure, but think about that warm, connected, human rapport, respect, all really important stuff. And if we get it right, we're standing, you know, we're setting them off on a good path. And then I move into the resources that are available. These two are fantastic. I'm sure you're aware of them already. Some of you would have been involved in developing them. And the next one, I think, are the references. And that is me this morning. Thank you.
Thank you, Gail, and for doing that in such a whistle-stop time, that vast amount of information. And again, just to let everyone know that those slides will follow through. Fascinating. I'm sure the questions are going to come around some of that neuroregulation, chance and choice, a number of claps I can see across the screen, but how we, you know, a really good start to this session in terms of how we then think about how we engage with young people and manage some of our services. While we've got Gail and Arvind with us, from my point of view, I guess what's really interesting is we, as paediatricians, we do tend to think about us pushing and taking those children through into transitions. The fact that that framework is just as applicable to adults with long-term conditions in patient-centered care, and actually particularly with the patient-initiated follow-up coming in much more for long-term conditions from that side of things. Be really interested to hear from any adult colleagues that are with us today in terms of in the chat how they might be able to use this. And I guess, Gail, that's going back to your element of conversation, and we all have a neurobiology that changes over time, and actually some of those challenges are still there for our adults as well within that. I didn't know if that was something that anyone in particular wants to pick up in terms of questions, or whether
Can I just say, we've done a lot with very little money, and if we had money, we'd be able to do a lot more. And it's about sharing practice and breaking down silos. I saw recently, and it is frustrating because children aren't always at the table with a lot of these discussions. And it is about breaking down, because if we work in both directions, we can make huge strides working together. If work is being commissioned, do think about asking us to be part of the group, because we've got people from up and down the country. We've got Yinsent Say, and Rosemary's also now part of the Transition Collaborative as well, or the TIER Collaborative. So do get in contact with us. And we've got people that are in high places within the associations, like the presidents of the BAPN or the Renal Association or the Nutrition Association. So with that, you've got to get the associations also working together. And if there's any commissioners in there, please get in contact, guys. I'm getting tired of sounds awful. I've had lack of sleep, but it's tiring when people take some ideas, which is great, but don't progress them as they could. And you could do a lot with just a few, key people working together for the greater good.
Thank you. And we do have commissioners in our audience. This is also, it's obviously one of the Children to Persons Transformation priorities this year. So we're fortunate, aren't we, in terms of having that come through.
Don't just commission the services within your own region, commission them outside and share, and just think, wow, guys, let's do this. We can make change across the UK by working together. There is no doubt about that.
Thank you. Louise.
Thanks, Ria. It was just a comment, really, just reading through the chat and picking through the details in there. I think it was really important to reflect that a lot of people have expressed an interest in taking forward the slides to be able to onwardly share that learning. And I think that was one of the key things, and I suppose one of the prime opportunities of the Huddle, to obviously allow that information to be disseminated to that wider workforce. So, there was a comment there for Dr. Duffy Pearce, and also a couple there around Dr. Nagra's slides. So really, really helpful. Thank you.
Well, one of the things I'm just thinking about the slides, please get in contact with me, because what I'm conscious of is people tweak them and change them. So I'd like to know where they're going. So if people contact me, then we can share the slides. But we just need to have a look at that. Yeah.
Thank you. And as you said, Arvid, all your resources are available on the Ready Study Go website, aren't they, in that digital format as well?
Yeah.
I do have one question that I would like to pose, because we're all very much aware of the impact on COVID on our services, ability to deliver services, that impact on young people's mental health side of things and their engagement. So a question to Gail, and then Arvin, your thoughts in terms of, we've missed an opportunity in terms of service development services and actually being able to transition some of these young people effectively, because their final element of transition to fallen within this, or a significant part of their transition might have fallen at a time where perhaps we've had less face-to-face or digital contact with them. And in terms of the impact of that we might anticipate, or how we might help support adult colleagues and look at transition, do we need to extend that period of transition at the moment even further when we're looking at these young people with their long-term conditions?
So from my point of view, the idea of extending the period, as Arvin said, if we're working to join up the practice and the approach and knowledge sharing on both sides of the trans. Oh, can you hear me okay?
It's echoing.
Getting a bit echo there. If you can turn off your mics, everyone.
Louise, could you mute?
If we're matching it up, we then coalesce around the young person rather than holding them in one place and trying to make a best guess about whether we move them on or not. Undoubtedly, the pandemic has had a huge impact, and we need to play catch up. But I think we should be doing that by working together as professionals around the person, rather than expecting the young person to sort of do the shifting and changing. I don't know if that answers your question, Ria, and Arvin, whether you'd have anything else to add there.
Yeah, if you think of transition as patient empowerment, we should have continued doing that through the COVID. Certainly we were doing that. And I was surprised that people said they put their transition programs on hold. Certainly, I was surprised because I heard that somewhere else as well. So what we did was, and this has been, I think it's been great in some ways, the COVID, just for this particular reason, we were able to reach our adult colleagues virtually. So they would still join appointments virtually, so they still met them. And we did our handovers virtually, and that worked very well. There were no problems or issues with that. So that was one of the things, because certainly in Southampton they come, and I'm sure in your regions as well, they come from a large area. So we were able to empower, so transition continued. They met with the adult colleagues in paediatrics and in adults, so that continued as well. And with our youth project as well, which is the peer support and the social prescribing, that went virtual, and we've got some lovely data on that. Okay, we're now continuing our youth project and the social prescribing, and linking in with outside services, and we're continuing a blended approach. Some of it's virtual and some of it's face-to-face. So there's been innovative ways of learning. So if anybody's interested in that, do get in contact with me. And really, you can. So, adults can't travel all the way to you, and you can't travel all the way to them. Patients don't mind as long as they can see them. That sense of relief, just knowing that they're in the room, or you've got a photo of them with with you and them, it just shows that you guys are talking. So it would work. So yes.
And Ria, you asked about sort of the mental health impact of the pandemic and navigating that. I mean, certainly as a clinical psychologist in adolescent health, my contacts with young people doubled during the pandemic. People that were kind of on my caseload into the pandemic, some that kind of got back in touch with me, as well as some of the the new ones that were coming through, wanted more regular contact, more brief contact, and the virtual technology really enabled that. So I think that there's some things that we can kind of keep hold of about how we how that technology worked for us. I'm finding that my work now is settling back down again, you know, the sort of additional anxieties around the pandemic seem to have, you know, it's not that I'm kind of holding lots and lots of people with sort of more brief irregular contacts. It's going back to a different shape. But certainly the virtual technology, I wouldn't have been able to do that if I was looking around for rooms and trying to bring people in when the hospital was, you know, all 2 meters apart and sort of on a bit of a shutdown. So there are things we can learn, and certainly a sense that in our work in mental health that we kind of ramped up, not down.
Yeah. And I saw Rosemary's comment that virtual clinics, I prefer face-to-face. Many of the young people prefer face-to-face because you can get visual clues that you can't get virtually. So the preference would still be face-to-face because you've seen it, things get missed. And so all this thing about, you know, having the patient at the heart of it and doing all these virtual clinics, which is what they're pushing in adults, that won't work for this, won't work for some of these, for a significant number of these patients, because you're going to miss those clues. And when you see them face to face, it's much easier to get that relationship tighter. So I do agree with that. Yeah,
absolutely agree.
A role for digital where we need it, and perhaps videos to introduce where they're useful as well. I'm really sorry that I'm going to need to move us on, because we do have our next group of speakers that to continue the conversation that we have. So I did want to welcome the Me First team from London. So we have Nicola Garb and we have Roshan Paquette-Simpson with us for the second half of the session, really picking up on that communication for children, some of that lived experience and how we might be able to communicate better, which I think picks up beautifully on the last comment and the fact that we've said in the chat that actually young people aren't necessarily going to prefer digital and might be actually telling us something quite different.
Thank you for inviting us, Maria. Yes, I'm Nicola Gorb. I'm the lead practice educator of the Me First project, and this really segues brilliantly into what you're just talking about communication. And we have Roshan Paquette-Simpson. So Roshan is going to kick off, I think. Roshan, are you ready to do the slides for us about our project, what we offer, and our wonderful, hopefully wonderful new training package all around transition. So Roshan, over to you. I don't know if I can see you.
Thank you. I'm just going to say we are very time tight, and I do apologise. So what I will do is put my virtual hand up again just 2 minutes before.
Yeah, we'll have time. I mean, there may not be that many questions, so we'll just make sure we end as soon as we can. But we'll have at least 10 minutes for this. Roshan.
Can everyone hear me?
Bit louder, Roshan.
Oh, can everyone hear me?
Yes, better.
Okay, perfect. So hi, I'm Roshan. I'm one of the young advisors who bring a lived experience to Me First, and I've worked for Me First for about 5 years. So Me First is a child-centered communication project. It's been around since 2015, and it was a collaboration with Great Ormond Street and Common Room, and was funded by NHS England. But now we sit at Great Ormond Street within the Learning Academy. So one thing that Me First is, one of our ethoses, one of our principles is always to do co-production. So all our courses, all our training, all our models, all our resources have been reviewed and checked by young people and their parents. All our courses are based in evidence, and we also link in with healthcare professionals as well. So Me First, we have a suite of training. Everything starts off with our fundamentals training, which is our core foundation. And then all our training, you then go forward and you could do the masterclass, the health coaching model, you could do the safeguarding. And then today what we're going to be talking about is the transition. Each course has its own communications model. And then also we have resources that are specific to each course as well. And those are all freely available on our website. We also then have a suite of bespoke training, train the trainer models and advanced levels as well. So if we move on, all our courses, as I said, you have to do the fundamentals as our core training as well. And our fundamentals that we build on is our fundamentals all are grounded around the idea of developmental level, involvement and shared decision making, power and influence, difference and diversity, involvement and shared decision making, capacity and consent. Then we have also our website, and as I said, our other communication models as well. You can follow the QR code to have a look, but all our resources are available. Some we have developed, some have been shared with us, some have been adapted and changed, and this is freely available. And these are aids to all build on the communication that professionals already have, but also just resources to help us really connect and talk to young people. So today we're going to be focusing all around transition. So our course is all around the conversations around transition, and it's about looking at what is missing. A lot of the time, when we did a lot of our focus groups, we found out that young people were saying, you know what, it happens a week before I'm meant to transition, and it's just a transfer. So we're not talking about that transfer. We're talking about what happens before we transfer them over to adult services, really grounding at the idea of what are the conversations that need to be happening, who needs to be involved, what are the type of people that we need to be integrating with to actually make sure our young person is having a smooth transition so their care doesn't fall off the bandwagon. So these were some of the pieces that some of the young people had said. But one of the quotes that I find really powerful was what a young person said. They said, "I was told 2 weeks before turning 18 that the service could no longer see me, that I would need to transfer to adult services. I wasn't given any choice or options. I was just handed over. The service the professional chose didn't meet my needs, and I had to wait 6 months before I was connected to the right service." This is continuously happening. This is not just one story. When doing our focus groups and talking about transition, a lot of young people said this is what they were going through, but also the fact that a lot of the time they weren't given any clarity. There wasn't a lot of preparation. There wasn't a lot of guidance around what they needed to learn beforehand. Becoming independent around your healthcare is quite a huge step. You shouldn't just throw them in. A lot of them were talking about their culture and how that can affect their transition. And actually, a lot of the time, the parents and their adults are in control of their care. So they started us looking into actually what are the ideas and support that young people need around having these conversations. So we then developed a mock-up of our training and worked with the Burdett Trust and their leads in transition, and they helped us kind of refine our training. But then we decided we're going to need a whole new model. So then we went and we developed a whole new model, really thinking about the language. Actually, we want everyone to understand it. We wanted it to be meaningful to the young person as well as the healthcare professional. We worked with focus groups. So we went to the Anna Freud Centre at their participation involvement event where we talked to professionals, young people, and parents. We also spoke to the youth forums at GOSH as well as the NHS Youth Forum, and then we ran quite a few focus groups with professionals. We have a communications champions as well, so people who have done our training looked at it as well. We are now going to be running the pilot in July, and then we're going to be moving and delivering and running out the course in September. So the model itself is a amalgamation of our masterclass and our health coaching. And what it looks at is having linear conversations. The idea that we want people to actually be starting to have conversations earlier before that transfer, but thinking about connecting with that young person, really listening to what that young person has to say and what is their here and now, looking at where they are, where they're heading. Are they going to university? Where are they going to be? Actually, where does their medical treatment need to be moved? What is their vision for their future? And how can you as a healthcare professional and everyone else involved help them achieve that? You want to review this. You want it to be review this and then check on the progress of this. So it should really be a continuous conversation. That's why the idea is that you can go back and forth between each point. Each section in this model should be broken down, and you don't have to complete. This is just a guideline and a framework to how a conversation should look, but you don't have to complete it all in one conversation. You might just spend one topic talking about connect and listen, the here and now for that young person, and going back and forth. Transition should be a continuous conversation, not just this is going to happen and then it happens. You might get it wrong. You might have options that don't fit that young person, and you need to work with that young person, being holistic to move them forward. I'm going to hand over to Nikki now.
Thank you, Rashan. Fantastic. So what does the training course? We're going to be doing a training course. The fundamentals is a 2-hour course, and then the transition module is a 4-hour course, which really gives a space and an opportunity for people to reflect on and discuss the challenges and opportunities for conversations with young people who are journeying through the transition time, and to introduce the model, to have demonstrations of that, to then have opportunities to practice that with examples we provide and video materials, and then also doing small group work to maybe discuss and try out these conversations in small groups and through role play discussions and reflections, to then really think about what are the next steps. And I really loved Arvin's outcome tool. So how can we then be measuring this, both from the perspective of the healthcare professionals' confidence and skills, but also the young person. So I'll be in touch, Arvin, about it. It's wonderful. So it's a real opportunity to do that. So it's all very well knowing what to do, but it's how to do it. And what do we do when things don't go quite so well? How do you do this when a parent will sort of really challenge that, or a young person isn't quite ready. So it's looking at difficult, challenging, as well as the standard everyday conversations you might be having. Can you go forward? So as we said, I know some of you on this meeting today will be coming to our pilot. I'm very excited about that. And then we just put on our website already some transition training, the fundamentals courses, which you can access and book onto via our website, which will be at the end. And there's at least 3 training dates put in the diary for the autumn for the transition module, but you do have to do the fundamentals before that can be done on the same day or a different day. So it's for you. We'll be very excited about that. And then just finally, we do the bespoke training. We've done some great work with an organisation to look at not just the general models and principles, but looking at how do we create a cultural shift, organisational change? How do we change our practice? So that was an opportunity, part of our module, to have that framework of discussions alongside the general training. Birmingham hospitals, University of Birmingham Trust have just completed our train the trainer model to deliver the fundamentals, and there's scope to actually deliver to do that train the trainer for our other modules, including transition. And we can do in-house training for organisation as well, just as a standard programme, and we're going to be doing that as well. So finally, just to give us information how to find us, there's some QR codes. You can book straight on, you can contact us, you can call us. I'm happy to have conversations, discussions about next steps. But I'm really keen to get this evaluated as well. So I'm working with some people on that as well. How can we show the effectiveness of this? So it's very much the how of the what. Thank you very much. And any questions?
Thank you, Nicola and Rochelle. We're going to hold questions if you're able to stay with us, Nicola, until the end of the session, so we can join some of that together, if we may. So we've heard so far about the adolescent brain. We've heard about a framework from Arvind that perhaps we can use when we're talking about transition. We've just heard there from Nicola and Rochelle and the Me First team about a model and how we put that communication into that young person's context and culture. So the next talk we've got today is actually, okay, so how are we doing? So this is a piece of work that's been undertaken on behalf of the Child Health Wellbeing Network and linking with the Child Young Persons Transformation Programme responsibilities. We've got our 2 clinical network leads for that today. So I'd like to introduce you to Dr. Rosemary Thwaites and sorry, I'm going to caught you there, sorry, Flora McErlin, and Louise has been supporting them in her network manager role. So over to you.
Thank you. So yes, so we're going to talk to you about this survey that we've undertaken across the region over the past few months. I'm going to start. I'm on the paediatric rheumatologists in Newcastle with a particular interest in transition. I'm going to talk you through kind of the background to our work, the methods we used, and the results from the paediatric clinicians. And then I'll hand over to Dr. Thwaites, to Rosie, who works down in South Tees, to talk through adult responses and I guess our kind of recommendations and conclusions. So next slide, please, Anne. As those of us who work across both paediatric and adult services know very well, there are some really important differences between paediatric and adult services. Adult services are really busy and they're organised quite differently. And I guess the way that adult clinicians communicate with patients and the way they expect them to make decisions may be quite different to kind of approaches in paediatrics. And it's because of this that we've learned over time that we need to prepare young people for that move across to adult services. And as we've already talked about a lot today, transition should be a very gradual process, really giving our young people the time that they need to plan and prepare for the move. And we know that this experience of transition can make a huge difference to that young person's transfer. Next slide, please. There are several important national guidelines that inform transitional care. There's the NICE quality standard that was kind of developed and published in 2016. And then next slide, please. There's also, perhaps even more importantly, the transitional care recommendations developed by Gail Dovey-Pierce, amongst others, to support kind of clinicians delivering transitional care. So next slide, please. I guess for the next kind of quarter of an hour or so, what we're going to do is try and summarise the results of a survey across our region of transitional care, during which we compared what's happening across our region with these NICE and NIHR guidelines. The ambition was to kind of summarise what's currently happening, identify key gaps and share, best practice, what's working well across different centres. So next slide, please. We developed 3 separate surveys, one that we sent to all the kind of chief exec or directors of nursing teams across the region, one that we sent to all paediatric specialty or adolescent leads if they existed, and one that we sent to young adult leads, or if there was no young adult lead, to the CD for that particular specialty. You'll see that the responses from the chief exec team were really, really good, suggesting that they were aware of the importance of transition. Responses from the paediatric and adult teams are absolutely broadly in line with similar healthcare professional surveys. I think, is there a problem seeing the slides? You move on to the next slide. The survey was sent across to all specialties, and we had responses from all paediatric specialties and from almost all adult specialties. Next slide, please. So I'm going to talk you through our results in 3 different sections. Next slide, I'm going to start with feedback from the trust management teams. Next slide, please. So quite a busy slide, but essentially what you can see straight away is that the management teams did, on the whole, recognise that transition is a priority for their trust, for their hospital. Around half of hospitals have implemented already either kind of your welcome systems or developmentally appropriate healthcare training systems, either in parts or across the trust. I guess smaller numbers of trusts at the moment have access to either a trust-wide transition steering group or to available young person advice or input. Non-clinical adolescent team members, for example, youth workers or access to social prescribing, is relatively uncommon, but a number of hospitals did report that they are working to rectify this situation. The final and very important outcome was that at present, none of our trusts across the region have got a specific young person DNA policy, and this would be in line with NICE recommendations. So if you go on to the next slide, please, Anne. Thank you. Paediatric leads feedback. Next slide. What we can see here is that at the moment, just over half of paediatric teams who responded to the survey are offering specialised clinics for their adolescent populations. However, it remains relatively uncommon for paediatric teams to offer joint clinics together with their adult services. And what we additionally know is that of the teams offering joint adult clinics, only one of these clinics was reported as taking place in the adult setting. Out-of-hours clinics are also relatively uncommon, perhaps more common at some centres than others. And we know that this relates in large part to kind of availability of clinic space, clinic nurses, etc. Next slide, please. A range of transitional care services are being offered by different teams, quite a lot of variation between teams in the same hospital even, which is interesting. Majority of teams do offer to see young people alone and then again together with their parents. The majority of teams also do offer a programme of support, and that red bar is just to demonstrate that the Ready, Steady, Go system that Arvind talked about, one of the reasons we asked her to come and talk is that that's very much the most popular programme of support across our region. It's being used by lots of different teams, and it's being used by a number of adult teams as well as paediatric teams. So next slide, please. The majority of teams, I guess unsurprisingly, provide a written summary at transfer. Transition planning processes are less common, kind of happen in just over half teams. So some room for improvement there. If we move on to the next slide. Just very quickly, involvement of young people in service design and service delivery is happening, but not routinely. People are involved, I guess, young people are involved in 2 different ways mostly, either via kind of youth forum systems or via clinical research that kind of goes to the young people and speaks to them. So next slide, please. Overall, our paediatric teams reported that having a good working relationship with adult colleagues, plus or minus joint clinics with the adult team, made a big difference to the process of transition and transfer. Using a formal transition process such as Ready, Steady, Go also was reported as really helping people to kind of streamline and make sense of the transition years. Having access to a nurse specialist or to a transition lead, unsurprisingly, also made a very significant difference to the level of care that was offered. Overall, paediatricians responding to the survey across the region evaluated their transitional care as around 5.5 out of 10. If we move on to the next slide, kind of reports of challenges and barriers were very, very similar from different teams. Lots of talk about lack of space, lack of clinic space to see teenagers, and in particular, lack of adolescent-friendly clinical areas. Problems with kind of formal trust processes, so it was quite difficult for a lot of teams to set up an adolescent service. It requires time, it requires funding, and that often isn't in place. There was quite a lot of comments about a limited access to young people to kind of help develop an appropriate service. And finally, a number of teams commented about the challenges engaging with GPs when young people are transferred back to primary care for their ongoing care. Okay, so if we move on to the next slide, please. So Dr. Thwaites is going to take over now and tell you a bit about the kind of feedback from the adult specialty leads.
Thank you, Laura. Yeah, so moving on to the adults, so we had slightly less responses from the adult teams, but as Laura said, roughly about what you would expect with surveys of this size. So when we look at where the children were being seen, most children were being seen by adult only in adult only clinics. However, almost half of patients were offered a joint clinic with the paediatricians or were seen in young adult clinics, which are run by adults, but we're just seeing up to the age of 25. So that was good practice. And some were seen in clinical nurse specialist only clinics as well. Next slide, please. When we asked about whether there was a formal transition process offered, 2/3 said that they did offer some form of formal transition process between peds and adult services. And children were seen, as Flora had already said, within the paediatric environment on just less than half of the cases. Bear in mind that the adult physicians that answered this query will not have been from the same specialties necessarily that answered the paediatric response. So as we know, evidence shows that meeting the adult team before transfer is associated with improved clinical outcomes. So this is occurring in almost half of the surveys that we services that we surveyed. Thank you. Next slide, please. When we looked at what wider team members, there was only a youth worker present in one clinic, and that was actually the HIV clinic at Newcastle, which was a service that ran up to 25. Psychology services were limited. 8 services had access to psychology within their adult teams, and that was within the congenital heart disease service, diabetes, cystic fibrosis, HIV and cleft lip and palate service. And again, these are services where psychology is funded within their service as part of best practice tariffs, etc. As I say, a lot of them did have multidisciplinary team members, mainly nurse specialists when we dig down into the data only, but there were still some that were just the doctor only. Next slide, please. So again, we asked the similar questions about involvement of young people. So we can see that there is feedback on service design and delivery, and also taking part in research for young people. However, there is no real feedback post-transfer within the adult service as far as specifically about what their experience of transition or transfer between the services was. Next slide, please. That's just comparing with paediatrics. You can see there is more involvement in recruitment, and you're welcome, but they're very similar. Next slide. So we look at any formal tools, as we've had lots about Ready, Steady, Go, and as Flora's already mentioned, Ready, Steady, Go is used. Say only 6 out of the 36 services were using Ready, Steady, Go, but that was the most common, if any, formal process was used. Most didn't use, and I think the 16 to plus tool is quite a new tool, and I think that will be something that we would look to be advocating across the adult services, because I think it is a very useful tool for them, but nobody's using it at the moment. Next slide, please. So again, we know that outcomes for young people, as Arvin's already mentioned, that when they fall off, if they don't attend and they're not chased up and they're treated in the same way as every other adult in the service, then their clinical outcomes are poor. So there was some attempts to contact patients, and there were some excellent pockets of practice telephoning patients, but there was no standard, as Laura's already said. SIX did say that they did have a DNA policy for their transition clinic within their service, so they would always write, and they were the ones that would always write to the GP, the patient, the parent, and the referrer. And I think again, this slide just shows that there's different things happening, and people are doing their best, but there isn't a standard process. Next slide, please. So again, we asked adult services to rate their service. Interestingly, adults rated their service higher than the paediatricians, and that may reflect knowing what transition is and knowing what the transition process is. I think there's been a lot more advocacy and information about transition within paediatrics for longer, and it's only been over the last 4 or 5 years that it's been within adult services and journals, etc. So when we look at what works well, again, having that formal process and support, having the ability to have the MDT clinics working single-handedly on your own. A lot of consultants fed back that it was just impossible to do it within the time constraints. But people did recognise that there were bespoke approaches for certain conditions and that you needed to work with young people. Joint clinics with paediatric teams and working relationship with paediatrics were key for most people that fed back to us. Thank you. Next slide, please. So barriers were similar, so lack of the formal process, lack of the MDT, time and recognition. So transition in adult services certainly is very, apart from diabetes and some of the other more and cystic fibrosis, there isn't time within people's job plans to do joint clinics. And again, the commissioning joint clinics are not part of commissioning for most specialties. So it is more difficult, and people are doing this in their own time and as extra, and going across to the paediatric clinic, and that needs to be recognised more. There were no youth workers. There is, obviously, we're going to hear from the youth worker team at Newcastle in the next talk, but there are no youth workers within any of the other trusts, and obviously we've seen from work from Leeds that having youth workers involved in supporting young people attending adult clinics can be very helpful and improve clinical outcomes. Next slide, please. We tried to collate the responses, and we came up with these 4 key themes. Again, some of them have been mentioned. We've mentioned these already, but again, it's useful to take these key themes back to your specialty to think, well, how can we improve these things, and also to look at how you can put business cases in and things to try to improve these services for young people. Next slide, please. Okay, so a summary of our findings: that we know that transitional care, we've seen that all morning, helps children just not feel more prepared, but also has improved clinical outcomes. The vast majority of clinicians who were asked did recognise the importance of good transition, and there are some pockets of excellent practice which have been done by individuals and individual teams. There's also obviously some teams that are funded to provide transition, and they are more established. Move on, please. However, despite this good practice, compliance with national guidance is limited and is specialty specific and also geographical. So there's no consistency of services available across even all the services within the Children's Hospital at Newcastle. We also have seen that, as mentioned already, certain specialties are more funded, so diabetes and other areas where children who live in Newcastle, who are at the Children's Hospital at Newcastle, who are transitioning to the adult services at Newcastle, were more likely to have a more formal transition process than those who were transitioning to adult services in other hospitals in the region. The reasons for this will be multifactorial, but obviously we've shown that working relationships between paediatric and adult services are key to good transition. It's more difficult if you're working as a paediatrician in Newcastle to have good working relationships with various adult clinicians around the region, and I think that's something that we would hope to do with our forum that we set up, so that we do have those better working relationships. Next slide, please. So our recommendations for the Child Health and Wellbeing Network and for the region in general is that we do need to transition obviously is recognised by trust, but we do need that senior support, and it needs to be on the agenda to support clinicians and other healthcare practitioners to provide this. There needs to be better joint working and facilitating paediatric teams to be able to transfer patients to adult services across the region and not just within the Newcastle hospitals. And also there's a need to look at young patient engagement and feedback. So Flora and I hope to develop a region-wide transitions forum, which will include healthcare practitioners and adolescents and young and adults to look at what's working well, how can we support people, and also to develop some resources and forums for the Healthier Together website, so that people will be able to tap into those, both young people and health professionals, and with links to various resources that can be helpful and training days, etc. Next slide, please. And also the NHS improvement are looking at bringing out a competency framework, but obviously today is the start of our region-wide education and support for healthcare professionals, and we will hope to put on or signpost people to other education that will be available throughout the year. Next slide, please. So trust management teams need to look at establishing a trust-wide transition steering group. We saw that within those areas where there was a steering group, transition services were more established, and it's also helped to support the adult teams who this may be quite new to, look at trust policies, collect data, form 16 to 25s, and ensure that young people are involved in their care and training for their staff. Next slide, please. For individual clinical teams, we suggest that we would recommend that there is a lead healthcare practitioner. That doesn't need to be a doctor, from adults and paediatrics within each service that work together. This is the model that Leeds used, where they went through each individual specialty to develop their transition pathways. And again, those key working relationships we've seen are what is helpful and successful with transition. Next slide, please. Thank you very much. Thank you.
Thank you both for that sort of update on where we're at from a region, and really interesting to hear what those next steps are going to be, which brings us really neatly into the final part of the morning, which is actually to begin to hear about some of the young person's voice within this. So I'd like to introduce Dr. Neil Davidson and the Youth Forum from the Great North Children's Hospital to finish our morning with regards to the transition elements.
Okay, thanks very much. And I'm hoping this is going to be a nice cap on everything that's been discussed so far. So I'm Neil Davidson, one of the general paediatricians working at Great North Children's. I've got quite a long background in both healthcare and non-healthcare related youth work, stretching back horrifyingly about 20 years. And I've been running the Young Persons Advisory Group for North England since 2015, influencing research and healthcare in the North East. We've also started developing a youth forum this year, although I'm afraid that because of exams, I don't have any young people with me apart from pre-recorded videos they've done for today that I'm going to present at the end of the talk. And our youth worker coordinator is off on long-term sick at the moment. But as Rosie alluded to, we've just had quite a lot of success in the trust with a number of youth work positions finally getting funding. So it's a culmination of several years' work. So things may be about to change, and quite a lot of what we've been talking about is how we can influence the region, how youth workers can be involved. So it's exciting times. So what I'm going to talk to you about today is a project we've been doing for the last 3 years, looking at patient experience in children's and adults outpatients. It's a completely co-designed project right from the groundwork, and I'm going to walk you through how that co-design process worked, some of our findings, and then the young people are going to talk a little bit at the end about what they want out of future work in transition. So we had a medical student approach us back in 2019 saying he wanted to create a charity for adolescent transition because he'd been through terrible transition in physical and mental health services himself, and he wanted to make it better. And myself and a colleague chatted with him about, actually, we kind of need some data before we can develop a solution to a problem, and went through 22 iterations of designing a questionnaire with our Young Persons Advisory Group, which we tested and piloted and ran to what we hoped was absolute perfection. Obviously, it was nowhere near, but we tried our best. We role played it. We got the young people to revise and revise and revise, really drilling into what their issues were with transitional healthcare, what they wanted to hear from young people and their parents or carers, not just young people who were able-bodied and, quotes, normal, but people with additional needs, people with communication issues and learning issues. So we created a variety of different questionnaires trying to hit each member of that audience. We then worked with the young people, looking at their own skills, the people in our group, thinking about what could they bring to the project, how could they be a part of it, what skills did they need to train themselves up to be ready to deliver a piece of research, and put on some training days that themselves were co-designed with the young people, thinking about actually how do you talk to somebody in outpatients, what is confidentiality, how do you have a conversation with somebody safely, how do we problem and troubleshoot, and we did some role plays as part of that, had the research nurses presenting, and basically did a mini GCP training for our young people, and got them ready to actually deliver the work. Because initially we thought we were going to put the questionnaires out, and they told us off and said, not a chance, we've done all this work, we're actually going to deliver this project, you now need to train us. So we went into Great North Children's Hospital outpatients in the summer of 2019. We had young persons advisory group members independently going up to patients and carers and talking to them, and we had medical students helping out with that as well. And the young people and the carers independently filled out questionnaires so that there was no influencing of young persons' answers by their carers. So we give their carers something to do so that they couldn't influence. On the days that we were in clinic, we supported the young people directly through medical students. So we had sort of a tiered mentoring system and some debrief at the end of each session in outpatients to make sure that we dealt with any problems there and then. And the young people fed back to us afterwards. We got them taking field notes while they were doing it about their experiences and what they'd gained out of the project. And actually, there were loads of things that they gained. And several of our young people have gone on to university and used this project as part of their application. And we've actually had to tell universities off because they suggested that some young people were lying about what they'd done. And we had to actually say that, no, these young people did do this big project. This is all their own work. So we did 7 weeks of data collection through the whole summer of 2019. We had 10 YPAG members and 2 of our medical students helping out. And we thought if we were lucky, we might get about 80 or 90 responses. That was our target. But actually, there were 700 hours of time volunteered by these young people and medical students. The students were supported with a fellowship, which was very useful. And we gained, horrifyingly, 1,310 completed questionnaires, which anyone who's done questionnaire research with not just quantitative but some free text boxes might guess is why it's taking us 3 years to process all of this data. We got 556 paired questionnaires with parent and young person responses, so we could compare those responses, along with a number of patients who were there without a carer, some young people with additional needs, and several young adults that had actually finished and moved on to transition, though they were a much harder population to get opinions from because we had issues with accessing clinics, which is why there's so many fewer in that area. And some staff members responded as well, although I'm not presenting that data today. So looking at the paired questionnaires only, we had a suspiciously equal male and female split with a mean age of around about 15, which isn't that surprising given the topic that we were looking at, but a good spread from 13 up. When we asked them a very simple question, have you ever had a discussion about transition with your healthcare team? The tan sort of coloured columns are people who have not, split by age, and the green columns are people who have. And again, slightly disappointingly, even by the age of 16, it appears, and we're talking about meaningful, memorable conversations, it appears that only about a third of 16-year-olds in our services are actually remembering having had this sort of a discussion. Obviously, that's much fewer when you're looking at the younger age group, but even when you get up to the few 18-year-olds we still have in paediatric services, it's about 50-50, which is quite concerning. We looked at what people's care experience was like and how prepared they felt for transition. And in some ways, it was nice to see that most people rated their care as very high, but it meant we hit a ceiling effect. So it was difficult to see whether there was any impact of discussing transition within these services. But as far as what they felt about being prepared for transition, it was very significant that there was an improvement in how prepared people felt if they'd had a discussion. Not rocket science, not very surprising, but actually the mean age of that discussion happening was 15, and the information that was given wasn't rated brilliantly. It was about 2.5 out of 5, but just having any information made things better. And then we looked at actually receiving written information or a booklet or some sort of thing to hold in your hand. The impact was even stronger for how prepared people felt for transition. But this probably wasn't getting into people's hands until close to 16, and it was only 13% of young people got any sort of written information. And pretty much everybody who didn't get it wanted more. So the straightforward messages from that quantitative data were that the experience is good in clinic, but if you discuss or give information about transition, shockingly, it improves your care experience and how well prepared you feel for transition. But actually, very few people are recalling having these discussions, whether they happen or not. And they certainly don't seem to be receiving the information that people like the Ready, Steady, Go team who've presented to be very keen that we're giving to people. We then did some qualitative data analysis, trying to pull apart all of the free text boxes in the questionnaires. And we did that with the young people. Again, they said we have to be a part of the data analysis. And this is what it looked like on the day. If it's going to play, which it isn't, which is frustrating. That's meant to be a nice video of them doing this analysis, which is going to play at about 1 frame a second by the looks of it. So the breakdown of the data we pulled out of that was very much chiming in with everything that's been said so far. Meeting the team is critical. Not knowing what's going to happen, not knowing who you're going on to makes people worried, and actually just not getting information is not good enough. They need to meet the team, have some information, or at least know what they're going to look like and where they're meant to be going before transition. We're still pulling all of that data apart and are hoping to publish this soon. We've got a paper that is effectively ready to go, and I'm meeting up with the team next week to hopefully finalise it all. So there will be more that we're pulling out of this. But essentially, these discussions need to be happening earlier. And again, that chimes in with what others have been saying. The earlier we start this, the more likely we are to get through it in a timely fashion, the more prepared people are going to be, the more opportunities there are to meet the team, to get information and to have your questions answered. And that written information really seems to help. But actually, we need to talk to young people service by service about what they need, what they want. Lots of information coming out from the qualitative data about actually perhaps some patient experience would be useful. And we could very easily record videos of people talking about their experiences to share with young people, condition by condition. It could be done cheaply and easily using young people to run those sorts of projects. And the earlier we get this information to people, the better. We've continued to talk to the group about it and work with the Youth Forum on this, specifically looking at GNCH, and we'll continue to do this towards the autumn after our summer break. And when we finally had our first face-to-face meeting in 2 years with our group back in March, they really wanted to drill into it again and start thinking about this. And last week, the group have recorded some videos, basically just crystallizing all of this down into 30-second or 1-minute chunks of what they think is important. They've done all of this themselves, so you may have to turn your volumes up a little bit on your computers to hear it, because it is a bit quiet in places. But I think it really puts a full stop at the end of the discussions from today. It crystallizes a lot of what we've talked about, that actually this is what young people want us to say. So I'm going to hand over to them.
What do you think an ideal transition would be? An ideal transition would have a consultation with your family, yourself, and your previous doctors in paediatrics, and potentially even your future doctor in adult healthcare. And this would just mean that there's a smooth transition so that the style of healthcare you're receiving is maintained throughout, so attentiveness and empathy is maintained. And yeah, this would just comfort the patient, so it's not a stark difference.
Hi. We feel that there's a really significant jump for long-term NHS patients between paediatric and adult care. In order to bridge this transition and make it easier for patients, we feel that these conversations of transitioning up to adult services care should be started when the patients are younger. This would make the transition less of a shock for them.
We believe that the children should meet with the adult service doctor and the paediatrician at the same time so they can be introduced and build a rapport.
We think that it's important for young people to have the opportunity to face-to-face go into their adult services to see what it's like. This means it won't be a shock for their transition and it will be gradual. Thank you.
When should a young person move from child to adult care?
So we all agree that there shouldn't be a strict age when you must move, and it should be based on the maturity of the young person and whether they feel comfortable. Different areas of healthcare may be dealing with young people with more complex needs, so the cut-off age should be altered accordingly.
Yeah. How can we make a transition more gradual for the child?
The ideas we came up with were improving communication with young people, maintaining positive relationships between young people and healthcare professionals, and the appointments should be considerate of the young people and when they've got things on, for example, exam seasons.
What is the most important thing to get right? Making sure that the patients know what's going to happen, and this includes all the little things like if their bed is going to change, or just any small detail, because the little things make people feel uncomfortable. So making sure they're aware of that will really help them to transition. What age should this happen? Well, you should start having conversations as early as possible, maybe 14 or 15, to make sure that they really have time to prepare themselves so they know what's going to happen next. How could we make patients more comfortable? By making sure that they're aware of everything. Perhaps you could introduce them to their new nurses or doctors, especially if you're used to them, so that they can build some more trust and get to know them. Maybe they could go on a tour of their new ward or watch a video of a tour. Maybe you could hand out booklets about all the little changes that are going to happen so that they can best prepare themselves for the changes about to come. Cut.
And that's us. So again, it's really clear. I hope you could hear all of that, that the essential messages from the young people are more conversations earlier, meeting their team, and that can be physical or virtual, more information, more information, more information. They just want to know what's going to happen, because forewarned is forearmed. I think we would all be the same. If we're starting on a new journey with a completely new team, the more we know, the better. And that's what the young people want. That's what they've told us. That's what all the work that's been presented today has been leading up to. And now it's really the responsibility of all of us here to think about how we practically do it and measure that what we're doing is working. Thank you very much.
Thank you, Neil, and a perfect place to finish the morning within that. There is just one question that's in the chat box about any plans to extend that across the region that I'm sure that colleagues are going to be interested in a response to that one.
Yes, I mean, our group is already not focused on Newcastle or really the Northeast, it's North England. So we've got representation from all around the region within the group. Obviously, because of COVID, any plans to extend it got shattered. It was very much our plan that following on from this project in GNCH, we'd be looking at other outpatient departments. Those opportunities may be starting again soon as we all start to unlock. But it's very much what the group are interested in doing. And I'm hoping that a lot of the potential partners, well, I know they are in this group already. So it's that sort of work that we can definitely replicate. We've got all of the stuff ready. We know how to do it. It'd be really easy to replicate.
Fabulous. So we look forward to that rolling out and soon in the near future. Thank you. So we're coming to the end of the meeting. I'm just going to take a moment really to thank all of the speakers that we've had today. We've had a wealth of information, and hopefully we've had some consistent messages that the young people have just wrapped up for us there at the end, but hopefully it's inspired you to have some further conversations and to reflect in terms of what we can do differently back in our own organisations, taking this forward. From a timing point of view, I know that we will hear about some of those future plans that we've heard about from the Child Health Wellbeing Network and from the CYP transformation and those clinical leads in terms of what they're going to be doing with us as a region around transitions to help support some of those next challenges and next implementation moves to try and push some of this forward. But what I'm going to do now is just in terms of timing, move across to Jen, who's going to wrap us up from a child health wellbeing point of view with some of the future things that might be available on the horizon to us as a network. Jen.
Thanks, Ria. In the interest of everybody's time at this point, massively quick run through just of some things that might be of interest to you from a child health and wellbeing network perspective. So this has been one of our semi-regular Huddle events that we run on a kind of ad hoc basis. So these happen on different topics. If you're interested in coming along to more of this sort of thing, we will always keep advertising through our network comms channels for you. On the horizon for the network in general, we've got our summer newsletter coming out next month. So we do this quarterly. It's an excellent way for you to be kept informed of upcoming events and things that you might like to engage in with the network, and also your opportunity to contribute to it as well. So if you've got something that you want network members to hear about, putting it in the newsletter is generally a good way to go about it. So if you email the contact address on the next slide or two, you'll be able to contact me with anything you want to include in that. We've got a big focus on child health inequalities across the network. Obviously hugely relevant to transition as well. We had a big virtual event around child health inequalities a couple of weeks ago, which was really popular, really well attended, as has this been. So it's obviously a topic of great interest to people across the region. So there's likely to be a lot more coming up on that in the next few months. My colleague Laura Cassidy is leading, and lovely Anne, who's been moving the slide along, involved in the Healthier Together website and app development. So there's a few more slides after this. So when you get the slide deck, there's some QR codes for you to find out about how you can download it, what it's all about. It's essentially clinically approved information for parents and young people for common childhood illnesses, wellbeing advice, all sorts of stuff on there. There's plenty more information on the following slides that I can't go into in any great detail just now. And Louise's other work, in addition to all of the transition stuff, there's a whole CYP transformation programme of work that she is involved in around long-term conditions, asthma, epilepsy, other stuff in there as well. So Louise has got quite a big portfolio of work around this. If there's anything you'd like to contact her about, then I'm sure she'd welcome your approach. Nodding yes, great. Thanks. Next slide, Anne, please. This is when you get the slide deck, you can read a little bit more about what Healthier Together is all about. The image there on the right is a poster. There's some posters available that you can use to help to promote it in your setting with the people that you work with your colleagues. Next slide, Anne, please. This is a bit about the mobile app. You can download it on Google Play and the Apple App Store. It is health information for parents in their hand, basically, and the means for them to contact their GP surgery and link up with them. So it is a great tool to be able to use in your practice. Ideally, it will help to reduce things like unnecessary A&E attendances and help people know how best to access the NHS, depending on what their issue is. So it's a great tool for you to use in your practice, and we would thoroughly recommend you checking it out. Not that we're biased. Next slide, please, Anne. These are the QR codes. You can try and quickly capture it now if you want to, or obviously you will get the slides, which you can do it at your leisure in your own time. And that is Laura's email address at the bottom there. So if you wanted to have access to any of the posters or images to help to promote it, if you email Laura, she'll be able to liaise with you to arrange that. Thanks, Anne. Last one, I think. Again, when you get this, all these links are going to be clickable for you. So if you are not currently a member of the network, you can join using that link there, and that will put you onto our distribution list to make sure that you receive all future communications from us about anything and everything that we put out. So that's our newsletter, that's our events, that's our other Huddle dates, any items of interest that you might like to be engaged with. That's the email address that you can use to contact me about the newsletter if anybody wants to contribute anything to that. If you currently have some active kind of youth participation, CYP voice activity in your organisation, we'd love to hear about it so that we can reach out into different areas and with different groups of people. So there's a form you can complete to tell us about that. If you are part of a wider network yourself, we have a network of networks, and it just expands our reach as the Child Health Network as well. So that's a different form if you think you might fit into that. The link for the Healthier Together website, where you can also download the app. And then if you are interested in our next Huddles, which will maybe be another 1 or 2 before the summer, and then it will be the autumn, there's quite a few more coming down the line. Keep an eye on your inbox for that. Thank you. Back to Ria.
Thank you. So I can see that Louise has just added into the chat the next steps in there. I'd like to thank you on behalf of the Child Health and Wellbeing Network for attending today, for your participation, and we look forward to future conversations with you in due course. Have a good day.
Okay, I think that went pretty well.
Yeah, it was good, wasn't it? Yeah, it was brilliant.
Yeah, I really enjoyed it. Actually, the talks were great. They're interesting.
Is Harvey, are you still Harvey on the clinic thing?
My Arvin said she had to leave because she had stuff to do, so I wonder if she's just left it.
She's got clinic, unfortunately, yeah.
Yeah.
I don't know what my, can people hear? Can people hear me?
Yeah, hiya, Louise.
It's higher. Sorry, I don't know what's happened to my mic, my camera, and what have you. Yeah, I suppose. Yeah, there wasn't a lot of feedback in the chat really from people, was there, in relation to questions?
I think the meeting was too big, Louise. I find it tricky to put stuff in chat when you know there's that many people there. So I think that's okay, isn't it?
Yeah. I mean, I think it hasn't allowed people dialogue, has it? I don't think. For all. Oh, Ria's ringing. Hi, Ria. We're still in the meeting. If you're able to join.
Let me leave you the meeting. Hang on, Maria.
Hi all.
Oh, I'm so confused here.
Right, here we are, yeah. Oh. Where's Maria gone now?
Is that Rosie? I can hear.
It's Amelia.
No, I can hear Amelia on screen.